This podcast is intended as healthcare practitioner education only and is not a substitute for medical advice, diagnosis, or treatment.
Like anyone who has a thyroid condition pop up for them, they don't really know what the thyroid is until something goes wrong with it and how important it is. And I was also told that, don't worry, this is a good kind of cancer to have, which I think downplayed my ability to grieve my circumstance because I felt like I didn't have I wasn't worthy of doing that because it was a good kind of cancer to have.
The way I guess I'm initially ascertaining whether this is true textbook hypothyroidism or cellular hypothyroidism is really coming down to assessing the functional capacity of the gland and then the potential influences that could result in suboptimal functioning. So at the same time, I'm also matching up the likelihood of that with this person's symptoms and their history.
This is Bioconcepts Between Clinical Minds, the podcast that's open-minded enough to take in all sides of a clinical story. You'll hear from researchers, doctors, naturopaths, nutritionists and patients. We look at common clinical presentations through a different lens. It's open, frank and sometimes controversial. Nothing is off limits. Will it change the way you treat? We'll leave that up to you. In Season 3 of Bioconcepts Between Clinical Minds, we look at thyroid health. We talk to experts in the field who will take you into their clinics and share their experience. I'm Tony Chambers, and this is Bioconcepts Between Clinical Minds. In this episode of Between Clinical Minds, we continue the conversation, this time on thyroid cancer and cellular hypothyroidism with naturopath and thyroid cancer survivor Melissa Briggs and holistic dietitian Natalie K. Douglas. Brisbane-based naturopath Melissa Briggs was diagnosed with thyroid cancer when she was just 27 years old.
I did actually have a lump in my throat for a couple of years before being diagnosed. I was just worried about having it biopsied, but in hindsight, that's quite funny, given that they cut my throat open twice. But so that was, how it all started was that I was ignoring this lump in my throat. I ended up having what they thought was tonsillitis, but pretty severely to the point where I ended up in hospital for a week. And they were pumping me full of antibiotics and everything else, and nothing was working. And they were about to transfer me up to Tweed Hospital, and within a couple of hours, I turned a corner and actually improved. And they said to me, look, we want you to have an ultrasound of the back of your throat just to see what's going on. And that's when they did an ultrasound of the whole area. They were doing an ultrasound of the thyroid itself as well and picked up on the goiter that I had and instructed me to go and have a fine needle aspiration. So that came back as kind of undefined. So they just suggested to go and have a partial thyroidectomy to have it removed so they could understand what it was. And that came back as positive for cancer.
And can you remember that time, like the emotions and how you were feeling?
I think there was a lot of confusion. I had only just started my journey into naturopathy, and so I really didn't have much knowledge in health. And, like anyone who has a thyroid condition pop up for them, they don't really know what the thyroid is until something goes wrong with it and how important it is. And I was also told that, don't worry, this is a good kind of cancer to have, which I think downplayed my ability to grieve my circumstance because I felt like I didn't have I wasn't worthy of doing that because it was a good kind of cancer to have. So, it was a lot to process at such a young age, but I kind of just looked at it like, great, this is what it is. What do we do next? And I'm very much an analytical kind of person. So I just wanted the steps to improve things.
And so up until that point, had you had a thyroid condition?
I did have anxiety through my teens, and I kind of look back now wondering whether or not it was along the lines of subclinical hypothyroidism. They did test my thyroid levels before and after I had the thyroidectomy, and everything was within range. Knowing what I know now, I mean, within range, like who knows where I can't remember where it was sitting, but I do kind of question whether or not there was a sort of subclinical picture going on before all of this.
Do you know now, I guess through your own experience and helping other people with this, do you know what might have been the triggering or the cause of your thyroid cancer?
I think it was multifactorial. I grew up with quite a large history of trauma. I grew up in a domestic violence circumstance, and then I had chronic chlorine exposure. I was doing a lot of swimming squad through my childhood and teens. I grew up in a very volcanic soil area of Australia, and I know that is kind of linked with higher rates of thyroid cancer. I had multiple rounds of antibiotics throughout my teens for recurrent tonsillitis, and I had a pretty bad bout of Epstein-Barr virus when I was about 16 as well. And then iodine deficiency, I think, definitely played into it, just given the chronic chlorine exposure.
And so what is it like for you now? Obviously, you don't have a thyroid. So what are some of the things that you're kind of living with on a day-to-day basis as a result of that?
Oh, look, my journey from diagnosis to now has greatly shifted. I think, I thought initially, great, I'm on thyroxine, that's all I had to worry about and I could just move on. I think about 4 to 6 years in, I started developing all of the hypothyroid symptoms quite severely. I put 10 kilos on within the space of about 6 months. I hardly recognized myself in the mirror. I was so fatigued that I would be willing myself to get up off the floor and just do my job. It was very debilitating. Getting emotional even just thinking about it.
Of course, yeah.
Yeah, the brain fog was astronomical. And I kept going to my doctor and just saying, look, something's not right. Can you please test my reverse T3? I think something's wrong, because they just kept putting my dose of thyroxine up. And I think at the highest point I was on 200 micrograms a day, which is, in my opinion, quite a high dose, And so I ended up doing my own testing. My reverse T3 was sitting at 800.
Whoa.
Yeah, so it gave me all the answers that I wanted. And then I ended up doing my own research and finding a GP who was willing to prescribe a combination medication. So I changed to a combination of levothyroxine and tetroxine. And it was like someone switched on a light bulb. Like within a week, I was just feeling so incredible. Within 6 weeks, I was feeling like I was a whole new person. So it was pretty profound. So I'm a big advocate of, if you have had a complete thyroidectomy, just really watching your levels. And one of the biggest things is that with differentiated thyroid cancer that is originating from follicular cells, because those follicular cells have receptors to TSH, the primary goal with thyroxine use after cancer is to suppress TSH as low as possible to prevent any residual tissue being stimulated. And I think when you think about that, you're really kind of wanting to put someone into a hyperthyroid state to an extent. And the body's quite naturally intuitive, and it will over time try to correct that and balance it and produce more reverse T3.
And I guess, you did get emotional before, and I guess that kind of must sum up how many women, many people feel when they're in that state. They don't know what's happening to them, do they?
Yeah, absolutely. You kind of think, is it all in my head? Because they do start to, in my case, I'm not going to paint every practitioner like this, but in my case, I was kind of told you should be hyper, we don't understand why you're feeling like this. Are you sure that, it's not along the lines of depression? And, do we need to be thinking about antidepressive medication? So, and I hear this story from clients all the time that, they do start questioning, is it all in my head? And how do you communicate that to your loved ones and to your partner and family that you don't have the energy to be able to socialize and do all the things that you want to do with your life?
How has your lifestyle, diet changed over the course of your journey with it? Obviously, like you said, it's not just as easy as here, have this medication. There are the causative factors that you need to deal with.
I've been also battling with getting a diagnosis for endometriosis. So I have that additional concomitant condition that's very inflammatory and is naturally going to potentially influence my thyroid hormone metabolism. I guess throughout my entire journey, before I got diagnosed, I was very much burning the candle at both ends through my early 20s. I wasn't looking after myself. I was probably very malnutritioned. I was using substance abuse to kind of deal with trauma and all of that. So from the diagnosis, it definitely, in my opinion, I actually almost needed that to get me out of that circumstance and to make me actually look at my life and go, hang on, this is really important. You know, I'm not invincible. And then I started studying naturopathy, and that kind of started to build on that as well. And then as my knowledge around thyroid health has continued to improve over the last 7 years of clinical practice, I've added more bits and pieces in as well. I see my own practitioner regularly. I think that's very important. And making sure I'm really getting on top of a lot of nutrient deficiencies.
Do you feel like thyroid conditions are on the rise?
Absolutely. I think it's, I remember when I was first diagnosed with thyroid cancer, I think it was like the 8th most common cancer. I think that's skyrocketed to the 5th or 4th worldwide at the moment. So it's continually increasing. And I'm seeing a lot more younger females in their 20s being diagnosed. I'm also seeing a lot of young men in their kind of late 20s to 30s as well. So, I mean, I do predominantly see clients with a thyroid condition. So I would dare say that about 85% of my clients are thyroid clients. I do have maybe about 10% of those having had a thyroid cancer of some description, which, as one practitioner, that's pretty high, yeah.
Yes, that's significant. So why do you think you're seeing younger men and younger women presenting with thyroid conditions?
Look, I'd love to know the exact reason, but I think it comes down to, we're really not getting the trace minerals that we were decades ago, specifically iodine and selenium. I think that we're exposed to so many more environmental toxins these days. And, the primary example is, where does everyone spray their cologne or perfume? It goes straight on the neck, right onto their thyroid. Fake tan, it's with the rise of social media and everything being about how you present yourself, we're seeing a lot more chronic use of fake tan and a lot of other health conditions that are linked with hypothyroidism and certain kinds of cancers as well.
So when someone comes in, you said 10% of your patient population would have or have had thyroid cancer. How do they normally present to you?
But I'll kind of explain that where I can best support them is once they've gone through that medical model to actually address the cancer itself. And then after that, it's about building on their health and really gaining that foundation so that their cancer risk moving forward is reduced. So that will look like, it will be heavily dependent on what's kind of been going on for them, whether or not they've had a partial or full thyroidectomy, whether or not they are on medication or not. It's very rare to see a client that isn't, but I have had a couple. Whether or not they've had radioactive iodine therapy and how high that dose is, and whether or not they have any short-term or long-term interactions as part of having that RAI. So it really kind of depends on kind of where we go from there. We really want to be, obviously, all the things that you would usually do for a hypothyroid client. So reducing their environmental toxin exposures, understanding their triggers. Hashimoto's is a large trigger for thyroid cancer as well. Methylation as well. So if people have an MTHFR genetic SNP, specifically the 677T, they've got a higher risk of thyroid cancer. And also, depending on what kind of medication they're on as well. So if they're on monotherapy with levothyroxine, we want to be ensuring that their absorption and conversion of that is really well supported. often we see hypochlorhydria, liver dysfunction, microbiome imbalances that can all influence that, but also nutrient deficiencies like zinc, selenium, B6, iron, which are very important for that conversion. And then thinking about cellular utilization as well. So supporting mitochondria, supporting their blood glucose regulation, things like that. Yeah, I'm a big fan of anything we can do for detoxification purposes as well. If I can get clients sweating regularly, that's great. Whether it be sauna, movement, dry body brushing. Yeah.
Even just being out in the weather in Brisbane at the moment.
Yeah, exactly. You only have to step out your front door.
And then I guess obviously it depends on the person in front of you, but is there anything in particular that you would across the board kind of prescribe to most of your patients in terms of lifestyle, diet?
I mean, lifestyle, absolutely. Stress management is going to be number one. We know stress can increase that risk of cancer as well, and inflammation, full stop, as well as improving detoxification pathways, as I mentioned earlier. With regards to diet, I'm all about functional foods, so bone broth, liver powder, pre and probiotics where applicable, making sure that they're eating organic where possible. Not everyone can go completely organic, but if they can switch out as much as they feel comfortable with, that's really important. Minimizing plastic exposure is a big one with my clients, as well as making sure that they're minimizing their environmental toxins where possible. And the big ones for me are, the things that you have control over. So the quality of your food, the quality of your drinking water and your showering water, cleaning products at home, personal care products, sanitary items.
Natalie K. Douglas is an holistic dietitian, nutritionist and naturopath. She sees the full gamut of thyroid conditions from hypothyroidism to thyroid cancers to cellular hypothyroidism. She says cellular hypothyroidism can be challenging to detect.
So most of the time we're seeing normal or even optimal thyroid values on lab tests, but with a clinical or symptomatic picture of hypothyroidism. So, those classic signs of an underactive thyroid like fatigue, brain fog, difficulty losing weight or weight gain that feels unexplained, thinning of the outer thirds of the eyebrows, cold hands and feet, maybe some issues from a fertility perspective, a collection of those symptoms. So I think it's important to place an emphasis on clinical observation here rather than just pathology.
And how often are you seeing people with cellular hypothyroidism?
Well, I'm definitely a little bit biased here because the bulk of my clinical practice work these days is with women, though speaking with other colleagues in this space and drawing from the research, I would say more women are affected than men. In terms of age group, I would say in my clinical experience, women in their mid-30s to mid-50s, and perhaps because many of the drivers of cellular hypothyroidism or thyroid hormone resistance are more prevalent here in people that I'm seeing. So I do think being mindful of stress, season of life, so remembering that times of hormonal change, puberty, pregnancy, perimenopause can see an influence of estrogen on the thyroid, and also just stress generally. And I don't know any adult that doesn't have some degree of stress, and also recognizing that stress perception is just so subjective. So really trying to take your own perception of what that stress would feel like for you and trying to hear how that client is perceiving it and how that experience has been for them and what their process of dealing with it or not dealing with it is. Because in my experience, those that are proactive in getting adequate support, whatever that might be for them, versus kind of soldiering on or being a bit of a martyr, have different experiences of how that might show up or not show up in their body.
So if the clinical signs and symptoms can be very similar to hypothyroidism, but the pathology can be normal, is there anything that can differentiate cellular hypothyroidism from hypothyroidism? Is there anything that you're looking for in particular?
Look, I wish there was in terms of symptoms, but no, like in my experience, in terms of just how they're feeling, no, I think it's really about diving into a process of, I guess, gradual elimination and through their pathology and also their response or not or lack of response to your treatment that helps to kind of start to form a picture for you as a clinician.
So then what do you do? How do you differentiate them?
The way I guess I'm initially ascertaining whether this is true textbook hypothyroidism or cellular hypothyroidism is really coming down to assessing the functional capacity of the gland and then the potential influences that could result in suboptimal functioning. So at the same time, I'm also matching up the likelihood of that with this person's symptoms and their history, which give me confidence in how likely or unlikely it is that my hypothesis is accurate. So as a practical example, let's say someone comes in with all the classical hypothyroid symptoms we know, like fatigue, dry skin, maybe some constipation, low mood, brain fog, etc. I would run a comprehensive thyroid panel in these situations. So TSH, free T4, free T3, reverse T3 antibodies as a start to see if their gland has any signs of inadequate function. So here I'm looking for, are they making enough T4? Is it being converted to T3? What is the T4 to T3 ratio like? Does it look like the TSH is responding appropriately to the T3 level that's there? What's the ratio between T3 and reverse T3? I.e., is the body overproducing reverse T3? And I think just in that, you're getting a bit of an idea of whether things like where things are at a regulation level or a brain level, which is really what that serum testing is doing. And if they're looking seemingly normal, so it also rules out, overt hypothyroidism and subclinical hypothyroidism, and as well as thyroid autoimmunity. And, if I saw overt hypothyroidism or subclinical hypothyroidism in those tests that I just mentioned, then I'd be looking at what's driving these as my next step. So the things that are on my kind of list there would be, are there thyroid nodules? So to do that, you just get a thyroid ultrasound as a start. And then I guess if you're unsure if it's hot or cold nodules, you'd need a thyroid nuclear scan. But in this context, when we're suspecting cellular hypothyroidism, it's usually cold nodules if they're there. Are there inadequate resources to make thyroid hormone? So diving into those tests around dietary assessment, is there enough protein and therefore tyrosine? Is there enough zinc? Is there enough iodine? So looking for those really common things. Is there Hashimoto's there, which we'd find out with that thyroid antibody testing? And then moving on to the next step, if I did those thyroid markers and everything looked fine on paper, pretty normal, but the person in front of me was still like, Nat, like I still feel really terrible and I have all of these symptoms, then that's when I would be going, okay, well, something is happening now at a cellular level, I should say. And I would already have done some, I guess, general pathology, usually at the same time that I'm doing those TFTs. But if you hadn't, then definitely go about doing that. So things like iron studies, a CRP, your kidney function, LFTs, a full blood count, zinc status, selenium, iodine, etc., if you haven't already done that. And I might be starting to look for signs of inflammation, knowing that inflammation can be a driver of cellular hypothyroidism. So I'd be looking at, okay, what's their albumin to globulin ratio like? Do they have an elevated ESR or CRP? Just little, and you can, of course, go into doing fancier things like cytokine panels and through functional pathology, but there's so much gold in just general pathology that you can pick up on. And the other thing that I would also do at this point in time to help start figuring out what is driving this person's cellular hypothyroidism or these symptoms of an underactive thyroid despite a seemingly normal functioning gland would be looking for any hormonal imbalances. So looking at their estrogen, looking at their sex hormone binding globulin, looking at progesterone and prolactin, and taking this into consideration as well, knowing that hormones can influence things. and really looking for in their clinical history and their current symptoms and lifestyle signs of stress. So are they under eating? Because starvation is a type of stress. Are they doing lots of exhausting exercise? Again, another stress. Are they suffering from depression? Again, perceived in the body as another type of stress. But what I was going to talk through, if you'd like me to, is some of the patterns that might appear with these different types of stresses on pathology results. And what that would be is things like type 1 stresses, starvation, as I already mentioned, depression, exhausting exercise are some of the ones that would fit into this category. And often that pattern on pathology is looking like a low to normal TSH, a low or normal free T4, and a low free T3, but a high reverse T3. So again, you're going, okay, like this is starting to match up, and then we'll get to the treatment in a moment. And part of what's happening there is there's a lower TSH release. The deiodinase 1 and 2 are downregulated, and they're often the ones that are responsible for converting from T4 to T3 and I guess are more our activating type deiodinase enzymes. And there's also an upregulation of D3, which is the one, deiodinase 3, which is the one that actually converts to reverse T3. And there's also decreased protein binding. So you're starting to kind of look at patterns here, which is what I was saying earlier, is that not just numbers, but the patterns matched up with the symptoms, matched up to the person. And then the other type of stresses that exist are on the other end of the spectrum. So things like obesity or a lot of adiposity, endurance-based exercise, adaptation to cold fits under here as well, acute psychosis, and also post-traumatic stress. And usually the pattern here is a high or normal TSH, a high or normal T4, and also a high T3 and a low reverse T3. So what's happening here is an increased TSH, the deiodinase 1 and 2 are being upregulated and the D3 being downregulated, and there's increased protein binding. So even if you remember nothing else, just write down the patterns that I've mentioned there.
And I know you've gone through the stresses, but does it involve the cell danger response? Is that part of the mechanism there?
Yeah, I do think so, because we have to, if we even just bring it back to basics, like all our body cares about is surviving, right? And when there is a perceived stress, what your body then does is it goes, how do I become really efficient at using the resources that I have? So a really simple example of that is like someone who goes on a really low calorie diet and their body, and I'm sure many of us are familiar with this, their body goes into what we would colloquially refer to as starvation mode, which really is just like a downregulation of like, there is a threat in my system, and in this situation or in this analogy, it's a threat from not enough food intake. And so all I care about is this human surviving. So I'm going to start to be more efficient with the energy that I've got, and I'm only going to just put out the minimum amount of thyroid hormone, for example, that can just run this show adequately until this stress passes. And the same thing can happen with whatever stress or threat to the system that might be. So circling back to those stresses that I mentioned, that is still a threat to survival. So when we're talking about cell danger response, it's like, how is my body responding to a perceived threat, and does it need to protect me, so to speak?
So as far as this not being diagnosed is concerned, as in not diagnosed or misdiagnosed, what is the implication for people who live with this for a while and then it's misdiagnosed?
At a patient level, you're living in a body that feels just like you're living half a life. I think that your body is incredible in that it will always prioritize the most important survival-based functions. And, many people can survive in that state for many, many years, but the reality is you can't thrive there. And I know for all of us, we're in the business of making people live as healthily, as energized, and as optimally as we can. So I think for our patients, it's really, there's the physical layer of just never feeling like they can get out of first gear and being incredibly frustrated. And I think there's the mental and emotional, I guess, impact of feeling, in some of my patients' words, like they're going crazy because they feel like something is off, yet no one is acknowledging it, and they're getting ghosted a lot of the time, or gaslit, so to speak, I should say, not ghosted, gaslit in expressing what they're feeling. But it's a very elusive type of thing to just, it compared to something like Hashimoto's, to try and find on pathology, which is how I guess the mainstream medical system bases diagnosis on primarily. And so I think it's really that physical and emotional impact.
Is there something that you can be doing to kind of help their symptoms in the short term as well while you're dealing with the cause of the cellular hypothyroidism?
Look, I think anything that you can do to manage the current stress that they're experiencing. So that obviously varies from person to person. So a few examples would be, if you've got the person that one of their stressor is that they're over-exercising and under-eating, then correct that as an immediate thing. If you've got someone who has been following a plant-based diet for several years, and you know that they're going to be likely deficient in things like vitamin A, zinc, iron, and they're open and willing and comfortable with incorporating some more animal-based foods, then do that. If it's a matter of, an emotional stress or something that's there that hasn't been dealt with, then I'm often encouraging clients, if they're open and ready, to start to address that with some form of therapy. Or the other thing that I actually find very helpful is anything that's getting people back into their bodies. So that could be things, and this is where shared care is just amazing for our patients, is things like massage, acupuncture, dance, like breath work, anything that is, if it's appropriate for this person, getting them back in their body to just start to allow them and empower them to release some of that stress that they might be holding in their body. And sleep's just the number one. And I know probably some people like, but what nutrient and what herb? And I have to say, I don't necessarily think that they are the thing that's going to make the biggest difference in these patients. They're absolutely helpful when you've identified their cause and are going after that root cause. But in terms of immediately what's going to help, I think, though, in my experience, those other things have a more immediate effect for people. As far as just to play along with the game of nutrients, so if I was going to hedge my bets on a few supplements to kind of bring in, I have to say magnesium, zinc, vitamin A, vitamin D, B vitamins, if the B vitamins are relevant to that person, depending on what you've assessed as their dietary status, etc. I think at sensible doses, I don't think you can go wrong with those. And I do think that they are so helpful because a lot of those come into play with mitochondrial function across the board. So when I'm thinking like bang for my buck, I'm thinking that. And then a beautiful herbal formula that is going to be very patient dependent, but using things that are relevant for that person in terms of some adaptogens, is good. But I don't have like a few that I'm like, yes, these ones all of the time, because I think each person's situation and their constitution is a little bit different. But I trust that the people listening will go, yeah, I know what an adaptogen is. And I can have a look at that toolkit there and pull some out from that. But in my experience, I will say one adaptogen that is, got good, strong research around it for thyroid health, where it's appropriate, and clinically I notice a nice difference, would be withania.
Just regarding, you mentioned people who've been on plant-based diets for quite a while and can be deficient in some of those nutrients. Do you find that common, given the increasing number of people following a plant-based diet? Obviously, you know, if they're supplementing themselves along the way, it can be fine. But have you found an increase in that side of things?
I really have, to be honest. And I think there's so many reasons for it, but what's really difficult as well, and I'm sure I'm not the only practitioner to notice this, is that depending on what their diet's been like before they go plant-based, if it's, you know, quite processed or they're not being super mindful and then they go plant-based and they're all of a sudden starting to eat more vegetables and fruit and being just more conscious and intentional with their food intake, then anyone's going to feel better in the short term. What tends to happen is that it shows up in the longer term. And by that time, in my experience, a lot of people have already started to self-identify and start to create an identity around being plant-based, and to let go of that feels like a even bigger loss than it would otherwise. So I do think, yeah, and you know, I'm all for people making their own choices, but I just really like them to be informed choices. And I think that part of the problem with plant-based diets for us practitioners is that people often will report feeling better before they feel worse. So that connection with like action and symptom is a little bit mismatched. So it sometimes can take some education on our part to let them know, well, hey, you don't deplete through these key nutrients overnight. It can take some time, and this is how it might show up. And doing some testing, having those conversations, and seeing where their limits or their head is at in regards to their relationship with that, and supporting them within that to the best of your ability.
In the next episode of Between Clinical Minds, we continue the conversation, this time on the impact of environmental toxins and stress on thyroid function, with nurse practitioner Ash Young and a Hashimoto's patient. Thank you for listening. We hope this podcast engaged and empowered you. And thank you to all of our experts. You can read more information on each of them on our website, bioconceptsengage.com.au. If you enjoyed this episode of Between Clinical Minds, please refer a friend and share the love. To continue the conversation, you can contact us at bioconceptsengage.com.au, where community is more than a concept.